How do you know if your sleep challenges are more serious sleep disorders? This episode will help you navigate where and how to diagnose a serious sleep condition. In today's episode, we answer three key questions. What are 7 different sleep disorder categories in sleep medicine? How are different sleep disorders diagnosed? What are therapies to treat different sleep disorders? Pankaj Arora's interest in sleep medicine aroused when he joined as country manager in SOMNOmedics GmbH, a German organization in the field of sleep technology. Today he is certified in clinical sleep health. He also possesses RPSGT certificate, gold standard in the field of sleep technology. He has earned a Paediatric Sleep badge. He is the co-author of the well-acclaimed book RPSGT PEARLS. He is a faculty member in Indian Society of Sleep Research. Let's get started.
Hey everyone, I'm Deepa, light functional medicine practitioner, author and yogini, and you're listening to the Sleep Whisperer podcast, the only sleep podcast with conversations and meditations. I'm on a mission to share profoundly insightful sleep conversations with global visionaries that merge together functional medicine and ancient wisdom. Breathe in bliss through weekly guided meditations and let yourself enter the land of dreams. Together, let's unravel the pieces, get to the roots, and understand the right tools to transform your sleep completely. Through this podcast, I want you to dream the best version of yourself. It's time to regain hope and begin your sleep journey. Pankaj Arora, welcome back to the Sleep Whisperer podcast. And I know I loved the previous conversation with you where we went into sleep diagnostics. It was a popular episode as well. And today I would like for us to talk about sleep medicine investigation and therapeutics. And we'll talk about how sleep medicine classifies different sleep challenges, and we look into appropriate ways to know how we have any of those. And then of course what would a very skilled sleep practitioner do in terms of therapeutics for each of these areas. So I'm looking forward to our conversation, and welcome back Pankaj first of all. And let's talk about how would we categorize, what does sleep medicine categorize different challenges in sleep?
Hi, Deepa. Thank you very much for inviting me again. First of all, it was a pleasure last time also to have a podcast with you, and this is again my pleasure again to have a chat with you. Coming to your question now, you have asked for how do we categorize. So, if you look at the ICSD-3, it's International Classification of Sleep Disorders. They have classified sleep disorder into 7 different categories. For example, just in a layman language, one is insomnia. Then circadian rhythm disorders, sleep-related breathing disorders, parasomnias, movement disorders, hypersomnolence, and other sleep-related disorders like because of some medical issues. So each disorder has some role to play in person's life. And so just to explain, for example, insomnia is basically when you are not sleeping, when you are not able to sleep, or in the midnight you wake up and unable to sleep. So that is called as sleep maintenance insomnia or sleep onset insomnia. So this is one. Secondary the disorders like, for example, if you see the young people, they are generally sleeping late at night and getting, so it's a kind of delayed phase syndrome. And if you go to the older patients, they will sleep early and then get up also early. So it's basically early wake rhythm. But these are general, but sometimes obviously some patients will have the delayed phase syndromes, though they are not a teenagers. So we need to look at these things. Sleep-related breathing disorders because of some obstructions happening. So these are kind of sleep-related disorders. Parasomnias are basically when you do a sleepwalking, sleep talking. So these are categorized under parasomnias. Hypersomnolence is basically when you sleep more than desired. Generally, we sleep at 8 to 9 hours. That's maximum a patient will, a person, human being will sleep. But when you're sleeping a lot in the night also and during the day also, you are feeling sleepiness and sleepy. So that is called as hypersomnolence. So another is movement. I told you movement disorders. For example, you get a lot of leg movements during the night. So that is categorized under movement disorders. And also rhythmic movement disorders, where you have a lot of, for example, you're moving your leg whole night, your neck whole night, or head whole night. So these are categorized under again rhythmic movement disorders, or could be other disorders because of neurological issues or some uh, accident which has happened, and these disorders are happening because of this. But if you come back, so each disorder have some obviously needs to know how to diagnose these different disorders. So we need to look into this. That's very important.
So yes, I think you listed it out really well, and I just want to ask before we go into how do we diagnose these aspects. Could somebody have a combination of different types? So maybe they're having movement disorder. Is it black and white, or is there ways that we could have a little bit of some?
Very good question, actually, Deepa. Yes, it can be a mix and match. Obviously, you can have two different diseases together. For example, if a person can have obstructive sleep apnea, just an example, and he could have a PLMD also, periodic limb movement disorders. So it can be a combination. Second, this person can have an obstructive sleep apnea plus he can have a hypersomnolence also. Yeah, though obviously because of obstructive sleep apnea, there'll be kind of a excessive daytime sleepiness during the day, but it can also happen that this patient have obstructive sleep apnea plus hypersomnolence plus narcolepsy also. So two diseases can also intermingle. So that can happen obviously. But then you need to rule out actually clearly with diagnostics which disease we need to look into. It's only one disease or it's multiple diseases which is creating a trouble into the patient's life.
So let's go into how do we diagnose these different types. And I'd really love for you to, because when you're talking about that, I would love for you to also talk about where somebody has to go for these appropriate diagnoses.
Okay. Yes. So first question that how to diagnose the different disorders is, and as I told you, for example, I'm just giving again a basics. So for example, if a patient has an insomnia, so he is not able to sleep, uh, but he doesn't have an obstructive sleep apnea. He is only having insomnia, uh, and he goes to psychiatrist. Psychiatrist looks into it. Uh, he gives him some questionnaires. So it's a kind of a subjective thing or a sleep diary. But then how should we measure it objectively? That's important also. So then what this psychiatrist or a sleep medicine specialist will give him a actigraphy. Actigraphy is a kind of a watch which works on accelerometer principle, and it is worn on a non-dominating hand for at least 7 days, and then go up to 14 to 21 days also, to see how the patient is behaving in those 7 days or 14 days or whatever 21 days. Because what will happen, for example, when I'm talking to you, Deepa, my both hands are moving, so it means I'm awake, I'm alert during the day, but when I'm sleeping during the night, especially my non-dominating hand will not move, though my dominating hand can move. So in that particular patients, if they are insomniac, they will be feeling lethargic, they'll be lying down, sleeping, so their hand will not move. So this doctor will actually look into his this sleep wake activity for 7 days or 14 days, and then he will come to know actually this patient is, because he will not fill the sleep diary at all. Nobody will fill. For example, if you tell me, I will not fill the sleep diary that when I got up, when I slept, but this actigraphy will give you a good 99% good estimation of the sleep wake activity, and then doctor will come to know that this what needs to be done according, what medication needs to be given. So this is one.
And Pankaj, just to clarify, this is a specific device and not just a smartwatch. Am I right?
Yes, yes. No, no, this is not a smartwatch. This is actigraphy. It's called as, it is basically measuring activity of a patient, and it is measuring for a long time, not because for a night it might happen that this patient is not moving his end. But why we are putting for long? Because we are looking for a long-term activities of a patient during the day and during the night both. So this will be one for 14 days, at 7 to 14 days at least. So one. And second, coming to, for example, you asked, so this will also be useful for circadian rhythm disorders, because you need to look at when the patient has slept, whether he has slept at 2 a.m. or 11 a.m., and then when what time he got up. And it is also useful for shift work disorders, because some people are sleeping at night during the day, or they are sleeping during night, they are working, so they have some kind of shift work disorders. So this actigraphy will also help for this secondary disorders and shift work disorders. Uh,
And
yeah.
one more question, Pankaj, before we go on to the next version of this, is that you mentioned non-dominant hand, and I'd like you to just talk a little bit about that, because that's the first time I've heard about this. So could you just talk a little bit, clarifying what is the science of that?
So dominating hand and non-dominating hand is a very simple layman language, Deepa. For example, when I was born, I am right-handed. For example, I write with the right hand, I play with the right hand. So this is more dominating, and this has more power as compared to my left hand. So, for example, if some people are left-handed, they play cricket from left hand, or are there, so their left hand will be dominating more. So that's what it is. Non-dominating is where you use that less. That
Right.
is
So, what
non-dominating.
does that tell us? I mean, what I'm asking you is that why is this used on such an arm, and what's the science and the link to understanding sleep through using this device on that particular arm?
Yeah, that's what I'm trying to tell you. Because once, for example, I'm sleeping, my still dominating hand, for example, my right hand still will move. However, my non-dominating hand means my left hand will not move also, because it
Got
has this
it.
power also, you know. So that is what it is. That's why they put it in non-dominating hand. Understood. So now, if for example, I told you about insomnia, and now for other disorders, for example, if you are having a sleep-related disorder, breathing disorders, so that means the person is choking during the night, he has obstructive sleep apnea, and he's getting woken up many number of times during the night. So just to explain you brief again, obstructive sleep apnea is a case where you have obstructions in upper airway. So where your air or oxygen, in just in layman language, where your air or oxygen is not going into the lungs during the night because of choking in the upper airway, and it could be because of central apnea. It is one is this is obstruction happening in upper airway, but it could be because of central apnea, because your neuro brain is not giving signals to the body that you should breathe. So it is two ways. One is obstructive sleep apnea, one is central sleep apnea. Both are important. And what doctors, or what ASM says, American Association of Sleep Medicine says, that if you have these kind of obstruction per hour, more than five per hour, then it is a case of, if obstructive sleep apnea, if you have a daytime symptoms also. If there is no daytime symptoms, that it is still okay. If it can be more than five, but if it is between 5 to 15, then there is no daytime symptoms, it's still okay. But if it is more than 15, and if there is still no symptoms during the day, still you have an obstructive sleep apnea, and patient needs to be treated. So that's a kind. uh, for this diagnostics, we need to have a last time also, it is called as polysomnography device, which we need to put on the patient. A lot of sensors on the patient, from EEG to EOGs to respiratory channels, and where we see with the video, see what is happening during the night, and then evaluate, and then accordingly provide the medication or therapy to the patient in the day. So this is again a sleep-related breathing disorders. Third could be a parasomnias, where we see the patient is moving during the night. For example, a lot of children do sleepwalking. You must have seen it, small children. So we say, no, no, he's just walking. There is no problem. And I just read it somewhere there was a news actually recently that in Singapore, there was a boy went to Singapore recently. And during the night, actually, he came to the balcony and fell down. And then the parents were really worried what happened, because then they spoke to Singapore police, because this guy went there. And then he was a 20-year-old child actually. So, and when they saw this video footage of that particular area, they could see actually this boy was actually sleepwalking, and he sat on the balcony wall and then fell down and he died. This is recent news
I
actually.
mean, this
So
is
this is,
very,
and
very
they knew, and then
alarming.
very alarming. And they knew it actually. He does sleepwalking actually, and then they told the police, because because they were actually really thinking that because he went with his friends, and then they were thinking that somebody did some mischief, but it was not. So it was a case of sleep walking. It's a case of parasomnias. So in this particular case, also you need to do diagnostic PSG again, polysomnography, but with external some extended EG montage, means you need to have more leads, need to put on the legs, more put on the limb leads, so that they will do the hand movements also. And then you need to have a camera also along with it, because you need to see the movements. It's very important. Sometimes, for example, in sleep relating breathing disorders, which I'm coming back, maybe camera is not that important, because you are merely looking at obstruction levels, which you will able to see from the waveforms. But during parasomnias, you need to have a camera. It's very important, because you need to look at the movements also along with your waveforms, and you need to synchronize, correlate it. So this is again with the camera is important. Now coming to, for example, I told you central disorders of hypersomnolence, which is a case of, for example, narcolepsy or cataplexy, which is again a kind of a disease where I told you during the day also patient is again sleeping for whole day, and in the night also is sleeping. So then this is though this is again will be done through PSG only, but this will be done in the night, whole night PSG, and then also in the day you need to have one test which is called as multiple sleep latency test. So what will happen? You do a full night PSG, and after that, once the patient wakes up, you tell him to not to sleep again for 1.5 hours to 2 hours, and then again put some sensors, only EG sensors, because we know that this patient is not a case of obstructive sleep apnea or sleep relating breathing disorders. So he has some issues, because we have already diagnosed through PSG all night, and we could see that he doesn't have much apneas or obstructions. So, and then we need to do this MSLT, because he's still feeling sleepy. So then we do MSLT for whole day. It is a test for around 8 to 9 hours again in a day. What you do in this test is basically you tell the patient to sleep again, uh, and then you see in the test if he is sleeping within, say for example, within 20 minutes. We need to look at within 20. If he is sleeping within 20 minutes, if he sleeps well within 20 minutes, then you continue this test again. You continue this test for more than 15 minutes more. So 20 minutes plus 15 minutes, 35 minutes. So this is 35 minutes. But what we are looking at, we are looking at RAM stage in this particular case, because this patient is going into RAM stages very fast. So if he has gone into REM stage, then we know that we will wake him up. We will again tell him to wake for another 2 hours. Then we will put again. So this cycle will continue for four to five cycles. But if we get two REM cycles, then it's a confirmatory. It's not a confirmatory. It's an indication of that he's a patient of narcolepsy. And obviously, we need to have a camera along with it, because sometimes this happen with it, because narcolepsy come with a disease which is called as cataplexy, which is basically cataplexy is when it's basically sleep is mimicking into the wake stage. That is, sleeping is going into wake stage. So what is happening? This is atonic. Patient is like sometimes you must have seen patient is talking to someone, is laughing, and he's fell down. He was talking to someone. He heard a joke, and he started laughing, and he was felt atonic, and then went into sleep. He fell down and went to sleep. So it's a slight differentiation from narcolepsy, but it's a condition called cataplexy. So we also need to look at whether it's a cataplexy or narcolepsy, and for this we need to do this MSLT test. I'm not going into that clinical details because this will take a lot of time otherwise. Test for now, for I told you, PLMD, that is movement disorders, periodic leg movement disorders come into movement disorders. So again, for that, what will happen? It's not because of obstruction, patient is getting excessive daytime sleepiness, or because of narcolepsy, but because his legs are moving whole night. You must have seen, for example, my sister. She moves legs a lot. So I always tell, why are you moving legs always a lot, and especially you're sleeping? So what is happening with these patients is they are moving their legs a lot in the night. They are getting aroused, because they're not going into deep sleep because of this, and still feeling lethargic during the day. So we also need to do this test. This is called as PLMD, periodic leg movement disorders, or a restless leg syndrome. For restless leg syndrome is happening during the day, while PLMD happens during the night. Periodic leg movement disorders happening during the night. So for restless leg syndrome, we do not need to do the PSG, but we will still look for PLMDs. For that, we have to do PSG again, polysomnography test, and then confirm whether for example, if it is more than 15 times per hour in adults, then it will be called as PLMD. And for children, if it is more than 5 per hours, he is moving legs 5 per hours, then it will be called as PLMD. And again, the doctor or sleep medicine specialist will prescribe the medications. For example, he may give ferritin or iron, whatever is needed, he will give him, and then he will be treated accordingly. Similarly, for other neurological sleep disorders, they will do the polysomnography test, and then this will. So one more important thing is, once you do this test, obviously therapy is important, which will come to the next point.
Yes, yes, I think it's important because, and I'm glad you didn't go too technical, because see, this is for everybody to understand and just give them direction on where to go, what to do. So, if you could just give us an overview now of therapeutics. So, once you've tested appropriately and you know which of these areas somebody's having challenges with, what is the next step for them?
Yeah, for example, for sleep-related breathing disorders, this is the most prevalent. Obstructive sleep apnea is the most prevalent disorders, for example, out of all these. So for example, if you diagnose that patient has a OSA now, more than 15 or more than 5 with daytime symptoms, then obviously you need to be treated. So depending on you have two things. One is anatomy of the face. Why? Because ultimately we need to look at why the air is not going to the patient. So there could be because of nose, because of nasal septum deviation, because of polyps, because of adenoids or tonsils. So you need to look at these things. So and you need to put what will doctor do? He will try to prescribe a CPAP. It is continuous positive airway pressure, which will be. He will tell him to. Actually, first he will treat. He will put a CPAP itself in the sleep lab itself, where the patient come for diagnostic study. Either he can do a split night, means half a night he will do the diagnostics, and because then he has lot of obstructions, which is more than 20 times in whatever half at night, and then he will put a CPAP, and then see if the obstructions are going away. Or what he will do, he will put full night diagnostic study. Sometimes a lot of doctors will do full night diagnostic study, because what will happen, the obstructions will happen during REM stage, mostly during REM stage and supine. And REM, generally rapid eye movement, comes early in the morning. So, because if you must have seen that when we're trying to dream, so it is dreams are coming generally in the morning time. So the REM is a stage where we generally dream a lot. So he will do a full night diagnostic study, and second night he will put a titration, that is CPAP. What is our aim? If there is an obstruction, our aim is to basically, if you ask me in a layman language, the pipe, for example, a windpipe is getting collapsed during the night, whole night, many number of times. So what we need to do is we need to open that windpipe. That's it. Or we need to open that air. So we need to put some we need to give some pressure, uh, force some pressure through some air, and needs to get this open. So the CPAP does the same thing. It gives a continuous positive air pressure and try to open the airway when it is getting closed. So this now this technician or doctor does a titration study on a patient and see where this patient is going into deep sleep, and he is not getting the apneas, or he's not getting the obstruction in layman language, or he's not getting any apneas, and when is this airway is completely open, and when he's getting the REM stage also. So these three things he will see. He's going to deep sleep, he's getting the REM stage, and he is not getting apneas, and there will be a kind of a pressure, which patient is comfortable now, and he will actually patient will feel very comfortable during the when he will get up after the titration study. I have seen it personally. The patient will say, I have never slept this kind of I have never slept in so many years this kind of sleep, which is because of this titration study. And then whatever pressure he was comfortable at, and whatever apneas were eliminated, or REM sleep had come, the doctor will prescribe the same pressure for whole whatever life. He has to put in a CPAP unit with a mask, and he will be really comfortable. So this is one for sleep-related breathing disorders. But if he's still not comfortable, because obstruction can be because of lot of things. So then the role of ENT will also come into picture, because what will happen, they will do a DICE. This is drug-induced sleep endoscopy. So which they will do is they will put a patient on sleep, and then they will put an endoscope. It could be a flexible endoscope, and they will see where this uh, uh, obstructions are happening, because he could not tolerate CPAP. Ultimately, he was not, the CPAP didn't help him. So then still there is a problem, but so they will see where are the obstructions. So and then, for example, if there is an obstruction, so they because of large tongue, so it is not helping. Still, the CPAP is still not helping. So what ENT will do, they will probably cut the tongue piece, so that the ultimate aim is to get the airway open. So then the ENT will come into picture and then do the surgery, kind of a surgery, which will help him to get this open airway. Open airway. It can be UPPP and a lot of technical things, which we'll again not go into details. But then this will come into. And other thing is, then there are, for example, oral appliances also come into picture. Oral mandibular devices, where, for example, your tongue is falling back in the night and you are not able to breathe because of this. So you need to put some oral device where your mandible will be, where your jaw, low jaw will be put forward the whole night, and your airway will be open. So depending on the need, uh, this will be, modality will be changed. So, however, CPAP is still a gold standard, but because ultimately opening airway by giving a pressure, air pressure is still easy. Because surgery still, patient will not go for would not love to go for a surgery. But yes, in some patients where they are not able to go with the CPAP, these are the other indications. One is surgery, and other is oral appliances. Uh, the other thing which I can think is, for example, in case of narcolepsy, then there is no need for therapy, because this is another case of excessive daytime sleepiness. Then obviously you need to get this. He doesn't have a problem with obstructive airway. He has a problem with some other neurological issues, because of he's sleeping too long. So then the doctor will prescribe some medications to him, so that he is getting he's waken up during the day. He's still able to work during the day. So which will not again go to the which medication, but neurologist will give the medications accordingly. then the CPAP will or other appliances will not come into picture. Similarly, for PLMD, I told you periodic leg movement disorders, he will give iron or ferritin or some kind of medications. Again, this therapy will not, or equipment will not come into picture.
Perfect, Pankaj. I think that took us already. I found that it was there's so much information we packed into a little time. And of course, if somebody wants to get even more information, they could go to specialists like yourself. You have a website where you put out information, or anywhere that somebody who's interested to know more of the technical aspects can go and learn from?
So, if there is they need to go to the particular sleep specialist. Actually, they need to look at, as we discussed last time also, they need to look at particular sleep specialist, because ultimately, probably is not functioning well. This patient is not functioning well during the day. He's feeling lethargic or excessive daytime sleepiness. So he needs to go to the maybe to GP first, and then general practitioner, because he doesn't know, the patient doesn't know what is his issue. So he will go to his own GP, and GP will again guide him to the particular sleep specialist, knowing what could be the issue. So he will guide him either to neurologist or pulmonologist or psychiatrist, whatever, and then they will treat him accordingly. So that is the best way, I guess.
Perfect. Thank you, Pankaj. And I know we are almost out of time, but anything final words you'd like to share about this before we end the show?
Yes, I would love to say that if this is my personal feeling that that whatever problems or disease what we have, according to me, is happening because of sleep. Because if you are not sleeping well, your daytime functioning is not happening. So you are not feeling good. You are feeling lethargic, and lot of diseases, according to, because hypertension comes because you are not sleeping. Hypertension will always comes into picture. Your lot of other issues, pulmonary hypertension will come into picture. Then your kidney can also can come create some issues. So sleep is very, very important in men's life, in people's life. And so sleep hygiene is also very important according to me. So sleep hygiene is one aspect which we need to look into. Sleep on time. We always, always from the childhood we are learning that early to bed, early to rise makes a man healthy and wise. So we should follow this. That's very important according to me. So that's a end note I would like to say, that we should follow sleep hygiene and sleep on time, wake up on time, and then you will be actually healthy, and your mind will be healthy, your body will be healthy.
Totally agree with you that sleep is such a big connection. And I think you are so right also that a lot of us don't focus on sleep hygiene. Just this morning, I was having a conversation with somebody. He said he takes a nap from 5:30 p.m. to 6:30 p.m. and then he watches television and he's on his sofa till about 1 a.m. and then he goes to bed. And these are such simple things that we can do, which are so powerful in all health. But thank you again for coming, obliging me with this conversation. It's always a pleasure to speak with you. And I'm sure we all learned a lot today.
Thank you, Deepa, very much. It's always a pleasure to talk to you, and would love to have more podcasts with you always. Thank you very much.
In a world where there are always polar extremes between systems and beliefs, I've strongly started to believe that appreciating and respecting every practitioner, irrespective of whether I agree with their views or not. I truly feel that sleep can be divided into three categories. The first is that you have great sleep. The second is when you may not have a sleep disorder, but the quality of your sleep is compromised due to various root causes. This area is my specialty, and you can look forward to my book by HarperCollins in December 2023. The third category is those who need diagnosis of sleep disorder by a sleep specialist. I believe there is a space for several kinds of practitioners and there should not be any ego so that we can best support anyone struggling with sleep. After all, ultimately everyone's goal is the same, which is to make somebody feel better. Have a great day. This podcast is intended to provide helpful and informative material on the subject matter covered in the episodes. The podcast is not acting in the capacity of a doctor or a registered dietitian and is not rendering any professional healthcare or medical service. The information in the podcast is not intended as a substitute for medical advice or services or as treatment or cure for any particular health condition. The advice and tools contained herein may not be suitable for your situation. Any medical questions regarding contraindications and cautions or any questions on whether or not to proceed with any practices provided in the show should be referred to qualified health professionals before adopting the same. The podcast specifically disclaims any responsibility for any liability, loss, risk, personal or otherwise, which may be incurred as a direct or indirect consequence of the use of information from this podcast or the application, adoption of any of the information provided.